but it gives me great pleasure, and it's a real privilege to introduce our first from Nottingham, who's going to really highlight and showcase the excellent work that he's been doing in ward rounds and education. So Rakesh, apologies again for being late, and thank you so much. Looking forward to hearing from you.
Thanks for the kind introduction. I'll think hopefully you can see my slides. Okay, from the outset, I really want to acknowledge the huge contribution of the various organisations and institutions that have supported this innovation. And I also want to thank a number of other private and voluntary organisations for their support in making this happen as well. I want to start by reflecting over themes I learned from actually watching the on-demand videos of your collaborative over the past 6 months. It's been a huge resource of learning for myself, but I want to pick up on some of those themes and then move on to explain what we mean by education, training, teaching and learning before sharing our story, our philosophy and the impact from that innovation. So your reflections, first of all, from all the Mentimeter themes and from what I could pick up. When I watched through the videos, several themes kept coming up over and over again, all of which I'd like to say we experienced at the start of our journey too. Sufficient time, getting senior buy-in, keeping things simple, having structured and consistent processes that everyone signed up to, managing staff numbers and rota gaps, ensuring sustainability, and surely the most important, and I say surely, but having patients at the centre of everything we think about when we reimagine ward round processes, but not just having them at the centre. I would argue inviting them to sufficiently scrutinise what we do as well. In the last session, Matthew Cook questioned whether we should make lots of changes or whether we should, really have a radical think outside the box altogether. And I think our story, in a weird way, ended up doing a bit of both, actually. We tackled these challenges, as I say, along the way and demonstrated that actually you can overcome all of them with a bit of creativity and, I suppose, get to the end of that journey with a story to tell. And that story for us was at least 5 or so years in the making, but we were prepared to go on it. But I'm only going to focus in the time I've been given today on what I think is the essence of what we did. Good education, as described in the psychology or education literature, and quality improvement. And by good, I mean excellence in education. From my perspective, I think our teaching and training should be judged not on our teaching or just whether our learners like it. I think we need to be bolder than that. And we need to hold ourselves to account and actually demonstrate that our learners actually improve as a consequence of it. We wanted the education not just to be about teaching, but the learning and the insights individuals accumulated about their performance conducting independent ward rounds. And we also wanted to instill a mindset that this education was not just about a 4-month placement, but feedback they took into their next placement and future ones to develop their safe ward round behaviours. In trying to deliver best education, we needed to ensure our teachers had educational expertise, not just teaching experience. You can't really get educational expertise without having some teaching experience, but teaching experience alone in and of itself doesn't lead to educational expertise. We also put learning, i.e. what individuals know and what they can do over time, above what they can do at the end of a session or even at the end of a placement. And we put emphasis on feedback for long-term development above all else. So here's our story. For me, as a nephrologist, drugs are life-changing. On the one hand, they can cause irreversible kidney failure and be totally devastating for patients and their families. And on the other hand, they can prevent the rejection of kidney transplants and be life-sustaining and completely transformative. Prescribing decisions invariably get made on the ward round or as part of a ward round. And we were particularly interested in prescribing errors because they were happening amongst foundation doctors twice as frequently compared to consultants or other non-medical prescribers, which was also curious to us because these decisions must have started or been discussed on a ward round. So were they in effect a proxy of poor ward round communication or a general lack of decision making, oversight or leadership around the ward round? And by prescribing, we're not just talking about the writing of a prescription. Often when we think of prescribing, we think of a drug chart that looks a bit like this, with writing probably looks a bit like this as well. But for us, we saw prescribing as actually a complex process involving all aspects of medication: the initiation, the monitoring, the continuation, the modification of it. It's a task that demands a thorough understanding of clinical pharmacology and judgment to prescribe rationally for the benefit of patients. So just the type of task, one of many, that experts should do and discuss with others, including patients on their ward rounds. Our why was also motivated by the fact that prescribing error interventions exist, but they often tend to be about improving the writing of prescriptions rather than the wider context in which prescribing takes place. The complex cases, the clinical reasoning, the ward round, and that's either a ward round undertaken by a consultant or a senior doctor, right through to the one independently done by the foundation doctor themselves when no one else is on the ward. And it's this lived experience of foundation doctors, the existing interventions that at the time seem not necessarily to consider or prepare them for. Here's some findings from a GMC study. The nursing practitioners were just sending jobs and jobs and jobs my way. And so I'd get distracted and I'd come away from what I was doing. I couldn't. They wouldn't let me finish, getting sort of standing tapping. So I think basically time pressure and trying to multitask. I think I made that error probably because I was flustered and I had to run all the way to Guiney to do it. And secondly, just sheer inattention, I think. I was a bit rushed as well. And her partner was like going mental on the ward because he was drunk. And I think I was just trying to be as quick as possible. And perhaps the one that struck most for me, I think I should have looked it up because I didn't really know it. But I think I just convinced myself I knew because I felt it, because something that I should have known, because it's very easy to get caught up in and being, oh, I'm the doctor, I know stuff. And with the pressure of people who are maybe sort of a little more senior than you, thinking, what's wrong with him? You don't want to always be seen to be, what's that dose of paracetamol? And for us, from a medical education perspective, this was the moral imperative upon which to design the best we could. We wanted to better educate foundation doctors around individual ward round competencies and wardcraft, and so they could better manage being on the ward, making those prescribing decisions with confidence and competence. We took our inspiration, and it was around 2012, so no coincidence really, from those who really knew how to get the best out of the brightest in any generation. It was important we had an overarching philosophy for the design of the intervention, and for us, it was about trying not to ignore all those aspects that I've just shared which contributed to error, but to embrace them all and do lots of simple things to improve them. For us, making 100 things 1% better collectively would help us improve things better had we tried to just do one thing, completely disruptive as it may have been, but 100% better no matter how effective it was. However, it wasn't just about taking a slogan or a soundbite such as aggregation of marginal gains and saying we used it when we really didn't. We did use it. And we knew that we also needed to explain it and disseminate what it actually meant and how others should apply it. And it really was about understanding that philosophy, because from a quality improvement perspective, it's all about the data and the feedback loops. It's then making changes in response to what that data tells you. And educationally, that's about understanding what your intervention does. What is the effect size of what you're trying to do or what you're trying to use? Knowing how much bang you actually get for your buck is really, really important. Having the great and the good come and give talks may be effective, but in terms of an educational effect size, it's not very much. By comparison, having creative educational interventions which support individuals develop self-awareness and are feedback rich are effective, and by a lot. And we blended as many of these effective interventions as we could into almost a radical new innovation that was about doing junior doctor training completely differently, and that would help us give us the best chance of success. And finally, we made sure as a leadership team, we had top-down buy-in in and across all the organizations we work with. But as an operational team, we also made sure that we had complete bottom-up representation. We collaborated with the makers of the drugs and went as far as putting them right next to the consumers of the drugs, so our patients and patients' associations. We took the prescribers and actually put them amongst the checkers of those drugs. And we all put them all in the same place to make a totally new end-to-end educational solution. We've described that design and development in this paper published last year in Medical Teacher for those interested in learning more about it. But essentially our aim was to improve prescribing quality and safety behaviours on ward rounds of foundation doctors using a theory-driven intervention. And by theory-driven, we mean aligned to an educational model of how best to teach things and a psychological framework for how best to deliver behaviour change. And by quality, we included both competence and performance metrics. We wanted to prove our training worked, i.e. participants who went through the training were reliably observed to have developed those desirable competencies. It's amazing how many times we do training and no one actually checks to see whether the training's worked. And so we also wanted to demonstrate individuals were able to transfer their competence into the workplace, proving that the learning stuck and resulted in change in safe prescribing behaviour in the workplace. We use the IHA model of improvement to guide the implementation and study design, and this has also been covered in your previous session, so I won't discuss that here. So what was the training? Well, Matthew Cook encouraged us to be disruptive, reimagine ward rounds or ward craft totally. This was about redesigning an intervention that focused on the consumer journey, in this case, foundation doctors and foundation training program. Why do they currently get the usual education and the simulation in the way that they currently do? Why don't they get individualised feedbacks using the best methods from what we know works in sport or business in other sectors? We wanted to disrupt that traditional way of organising education across a 4-month placement, and this is how we did it. Instead of just being in the seminar room, we also delivered simulation at the start of the placement to identify what their ward round learning needs were over a 4-month placement. And we also gave them a learning prescription for that period of time. We delivered another simulation at the end of the rotation to identify whether they'd actually achieved these learning outcomes, again by doing a ward round independently. And what was novel was that we used the recording for the first simulation, so 4 individual ward round encounters with 4 different patients as the basis of the feedback that we gave them in the early weeks, drip, 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 feeding through, so that individuals could sit down and reflect over it just like they would do in a CBD or mini-KEX. Work-based placed assessment. And for those of you who watched the cyber presentation, this would in effect be an answer to how you could develop individual ward round competencies. To investigate whether or not this education was effective, we had a control group who got the simulations, which essentially comprised of them doing a ward round on their own with 4 patients, receiving standard or general debrief as they would do after any simulation run any trust across the UK. However, to be clear, the intervention cohort in addition got this video assisted feedback or teaching around aspects of their ward round performance using a recording of that session with 1 scenario each month debriefed in full regularly over that 4-month period. Here's an example of the setup, and if you can look very carefully in amongst the drip stand where the IV pumps are is the camera, so it's nice and discreet and it's picking up pretty much everything. And Margaret there, she's hooked up with a sound mic so you can capture everything. And we use real patients and not simulated ones either. You can't simulate a kidney transplant just in the same way you can't simulate an arteriovenous fistula. Authentic learning experiences were the hallmark of EPIFFANY simulations. The standard debrief was usual, with staff in their own organisation aware of the intervention and being a part of the implementation. This was the pull in, not the push away, but giving their usual feedback, albeit in a more focused way, but essentially by themselves. Our debrief, the added value, was given by one of our team using video captured on the day and played back at week 3, 6, 9 and 12 of the placement, and feedback was on their ward round performance. You can see their notes they made on the day are there in front of them, their prescribing behaviour and their clinical reasoning, i.e. their problem solving, their diagnosis, their differentials and their management plans. Another hallmark of EPIFFANY is the partnership with patients and carers, or local PPI groups. They all co-design the simulation scenarios and assess performance, participant performance, and share feedback on those aspects as well. So the results. This table demonstrates first and foremost that prescribing competency of those who get the regular video feedback from their simulations improve performance in a simulated setting. Whereas those in the control groups, they got everything, the standard simulations, the usual education, the training, perform no different at the end to what they did at the start. And this is really important because it confirms observations we knew from the wider educational literature, that education in and of itself can sometimes have little meaningful impact. It's an experience, yes, and they learn something presumably, but in this case, just not anything that increased their wardcraft in a way that it improved their prescribing competency. Okay, so we proved in that study that our education worked, but could we prove it made a real world difference to patients and workforce outcomes? We've described 3 studies that we completed afterwards to investigate this question in this paper, also published last year for those interested in learning more about it. And I'll describe them here very briefly. To demonstrate transfer of learning, essentially the holy grail of what we're talking about here in effect, we needed a slightly different study design. And as said in previous collaborative ward round sessions as part of this series, data is absolutely critical for demonstrating improvement. So we really didn't compromise over getting as much as we could. Data collection continued for over 8 months, 4 months with a control cohort and 4 months with the experimental group, or the intervention group, who essentially got the EPIFFANY training and all sorts of mobile technologies that are available out there to help them with their wardcraft. Again, we had to prove the training worked with this new study again. So we needed simulation center data about their competence and skill decay. But to measure those real world differences, we also needed to collect ward data. So every single prescription made by every single individual in the workplace, essentially anybody who went onto the ward, who received the intervention or not. And to demonstrate improvement in prescriber behavior, we needed to explore error rates per prescriber, the error severities across the different categories, to ultimately show impact on patients. And you can imagine how complicated that task was in terms of the paper charts and the volume of patients coming in through any given unit. Our novice controls were other foundation doctors on the rotations, and our experienced controls were other medical doctors above foundation training who didn't attend the training but worked on the wards and prescribed on the wards regardless. The experimental group was always a cohort of foundation doctors who got EPIFFANY training and feedback. The experimental group was split into 2, those who attended the simulations and got usual feedback from their ward consultants, group 1, and those who got the monthly feedback debrief videos focusing on their clinical reasoning, focusing on their wardcraft, and focusing on their prescribing, group 2, because again we were particularly interested in separating the effect of simulation and usual feedback given afterwards from the added value of regular video-based drip feeding feedback across their placement, covering those components which I've just mentioned. And here's the data for those interested in QI and science amongst the audience. There are a number of things to note from this table. So experimental group 1, they're the ones that attended the intervention but didn't get the video debrief feedback. They produced more errors per prescriber compared to novice controls. So these being those who got nothing. So remember, this is the group who attended and got the usual debrief at the end, but didn't get the monthly one-to-one feedback. They appear to do worse than those who didn't attend at all. Group 2 appear to do better than those who don't attend at all. So you could say, well, that was obvious because receiving education would intuitively seem to be better than not attending education at all. But however, if I put the two, group 1 and group 2 together, that's not the case. Group 1 attended and felt as though they'd learned from the experience by virtue of just being there. But as this data shows, being there at a training day doesn't necessarily mean that there'll be a change in behaviour in the workplace. Finally, if you compare the intervention group with experienced controls, and remember that GMC study demonstrated that foundation doctors were twice as likely compared to an experienced control group producing errors. Well, you can see that gap is now less than the double or twice as likely that it was before. It's still there, but it's less. And a bar graph just putting all of that information together from this first study, we're beginning to see that there may be some signal for this training suggesting that epiphany may be associated with sustained performance levels across those 4 months, and one that's associated with the lowering of prescribing errors over time. But could this be replicated, and could it be made better? And if so, could it be done at another hospital altogether? This first study took place on a renal unit, so one could argue it was a high-performing place to start with anyway, with lots of pharmacists around all the time. But so was it really the education that made a difference, or was it something else that could have caused the data to fall down in the way that it did? So we moved hospitals. And actually, we took on a greater challenge of moving to a trust and award setting where there were significant challenges around ward rounds and a significant number of prescribing errors on the ward as well above the national average by some way. Not only that, you can see by some of the nation's flags at the bottom of this picture, this was a challenged area demographically for foundation doctors to work in terms of English as a first language amongst patients coming into hospital, and poverty and deprivation. And it also wasn't a case of just rolling into town and delivering simulations. We ended up in a part of the hospital that was cordoned off, wondering how on earth to deliver education in this setting. There was also a problem with Legionella, we found, so we had to install hand washing stations at the last minute, but we managed to deliver the simulations nonetheless. And again, it's a reminder of the need to have senior buy-in, but also a team on the ground comprising a general manager, an educational manager, nursing staff, pharmacy, and junior doctor representation alongside patients, if this form of intervention is going to get spread, scaled, and sustained in the way John Dean's talked about in previous months. This table demonstrates the performance data in this new setting. It's a general surgical ward. As you can see, there's good representation across both groups. The experimental group got the simulation and the video-based one-to-one teaching feedback, whereas the experienced controls didn't. The first thing to note is that the significant volume of prescribing undertaken by those foundation doctors, essentially, they, compared to everyone else, average over 500 prescriptions per individual compared to less than 100 for the others. And if you look at the error rate per prescriber just below, we've now got them around the same as the experienced controls. In the study before, just now, you may recall we halved that gap, but now we just about equaled it from this bar graph. Again, another example of a marginal gain. We learnt what worked well in the education from study 1 in terms of wardcraft and how you improve that. And we took that learning and improved the education model for site 2. And here was the outcome. So I think we'd proved that the intervention could travel from one hospital to another. But could we step back And would that transfer still happen within the same hospital and across wards without us? And could it be sustained? Could we walk away? We wanted to find out. So we trained the pharmacist all about clinical reasoning, wardcraft from a medical perspective. They had all the knowledge about drugs and diseases, but not necessarily about making a diagnosis and about other aspects of management planning. But it didn't matter, not for the purposes of teaching foundation doctors. These pharmacists knew their context. In the case of surgery, they'd worked on the ward for many years. And in fact, that was more important. They'd been on the ward round, and that's all we needed. So we taught them how to be the best teacher they could be and how to give feedback in the best way they could. Here's the data from study 3, an orthopedic ward in the same hospital as study 2, but a different hospital to study 1. The experimental group again produced less errors per prescriber compared to the novice control, and by some way now. Not only that, but they were also prescribing a lot more items, as you can see. So it looks as they weren't avoiding the prescriptions, they were heading towards them. The experimental group were now better than the experienced control, again demonstrating a study-on-study increase in performance. And from a marginal gains perspective, again demonstrating that you can always improve at each iteration, and the improvements to education delivery were happening as we better were learning how to adapt to the context in which we were going each time, understanding the most important thing on the ground, the local culture and the relationships amongst staff. But this was the first time that we'd actually reversed that GMC study to statistic. So now foundation doctors were no longer twice as likely to produce errors than everybody else. Actually, they're better than more experienced controls, and that's all of us consultants and everybody else. So what have we shown? We've shown that by educating junior doctors on how to perform independent ward rounds, you can improve their performance in the workplace, certainly going on their prescriber behaviour. We've shown that if you use a theory-driven approach and one that draws from insights in education and psychology, you can design an intervention that you can make observations against a series of competencies and standards. If you use evidence-based education, education with proven benefits, you can train effective behaviours which don't decay over time, but in effect sustainably remain and scale. But, and it's the big but, does that even make a difference to patients? And if so, how do we know? In study 3, we looked at patient level data because we had it. So all the doctors who prescribed any medication for any one patient, and that data allowed us to analyse performance in this way. Patients seen by the experimental group suffered less prescribing errors compared to those in the novice control. So those other foundation doctors, and this crucially, they perform better than the experienced control. So any prescriber like you and I, who is prescribing now, and this is the first time this has been shown. The challenge with any education, as you know, or any educator will tell you, is engagement. And here is more in-depth case study analysis of individual doctors based on their engagement with Epiphany. They're all drawn from the experimental group across the 3 studies. So by definition, they've been exposed to the intervention, invited to receive the video feedback. But as you can clearly see, the individual on the left did not engage with the feedback sessions, only attended one and not a lot else. And you can see, if anything, their competence, like we've shown on numerous times with the data, their performance gets worse, which flies in the face of conventional wisdom that if doctors learn something by just actually being there. This individual also made a number of prescribing errors, including one serious error. The individual on the right, by comparison, attended all the feedback sessions and got hugely better in the simulation at the end by comparison. And look at that, they only made 2 errors for the whole 4-month rotation. So I want to end with this quote. Since the collaborative is about ward rounds, and on ward rounds we see patients, and when we see them, yes, we have checklists to fill out, and yes, we have information to gather from them, and yes, we have a number of things that we want to say and do to them, but actually it's fundamentally about a conversation with patients as people and as persons. As Gordon Caldwell always says, it's not just about what our agenda and what we should do. And as Margaret said about an epiphany trained doctor, I don't know what it was about the second group that seemed better, but the second group seemed better at greetings and goodbyes. A conversation with patients about their medication should have a beginning, middle, and an end. I know it's a little thing, but it makes a big difference. Thank you.